Thank you all for joining us today. This is a collaborative call with quite a lot of agencies, quite a lot of investment. We really encourage you to ask questions, to put it in the chat. It is about making connection today and further on. I'd like to introduce you to the NetHope CEO, Lance Pierce, to start us off.
Hello, thank you, Diana, and welcome to you all. My name is Lance Pierce, and I am the CEO of NetHope. For those of you who are guests today and may know us less well, NetHope is celebrating its 20th anniversary this year. We're the world's largest network of impact organizations working in partnership with the tech sector for transformational learning, collective programming to deliver real human and environmental benefit through the power of digital and data technologies. NetHope's nearly 60 members are the most effective impact organizations around the world in humanitarian relief, international development, and global conservation, working in 190 countries. And NetHope works to improve lives, livelihoods, and the environment in partnership with our members who represent more than 60% of all international aid dispersed through NGOs globally every year, as well as through our 50 extraordinary global IT and tech sector corporate partners who are on the leading edge of innovation in the digital space. So today's gathering is a milestone event in our ongoing strategy dialogue on technology for equitable COVID-19 vaccine distribution. And among the many things we do here at NetHope, we convene gatherings such as these with members and strategic partners to share their work, technology partners to share their digital expertise, and to co-create with funders, collaborators, and other stakeholders. And by way of past experience, NetHope is using the approach we developed as a first responder during the Ebola crisis, where we helped our members scale their impact and results through coordinating a multi-NGO effort across thousands of staff on satellite and internet connectivity, crisis mapping and informatics, data sharing and standardization that enabled NetHope member organizations to serve an estimated 22 million beneficiaries, saving untold lives in the process. And I'm really delighted to say that today's dialogue, which is the third in our series, is showcasing the work of a number of NetHope collaborators, as well as a later panel reappearance by our esteemed NetHope member, International Medical Corps, for an important launch event. Before we jump into our content, let me first share with you a brief snapshot about the worldwide state of play with the global vaccine distribution effort. Since our last call, the COVAX facility has now delivered life-saving vaccines to over 100 economies since making its first international delivery to Ghana on the 24th of February. More than 38 million doses of vaccines from AstraZeneca, Pfizer, and the Serum Institute of India have now been delivered. COVAX aims to supply vaccines to all participating economies that have requested vaccines by the first half of 2021, despite ongoing delays in planned deliveries. To meet its target this year, COVAX is seeking to finance and secure remaining 1.8 billion donor-funded doses of vaccines, and COVAX is also working to secure additional sourcing of vaccines in the form of dose sharing from higher income countries. As of early April, WHO was tracking on the order of 137 million confirmed cases of COVID-19 and nearly 3 million deaths worldwide. The world is waking up to vaccine equity as a critical moral issue of our time, and tens of thousands of people in more than 1,500 organizations, including a number of NetHope members, have signed on to the Vaccine Equity Declaration created by WHO to press for equitable distribution and access to the cure. And as we know on this call in this community, robust digital infrastructure and data will be a central and yet frequently underappreciated success factor in making sure that we deliver vaccines equitably and effectively. So to look at the intersection of NGO-led vaccine response and the digital tools that'll be required to overcome last mile challenges reaching the hundreds of millions in need, we've convened this third in a series dialogue today. After our first and second vaccine data dialogues, IMC, a global firm working on vaccines data via COVID Action, in partnership with the Foreign Commonwealth and Development Office of the UK, reached out to NetHope and to our membership and associated organizations about staging a dialogue in this series to engage the NetHope membership in the launch of an exciting new initiative. COVID Action is a partnership between FCDO's Frontier Technologies Hub, University College of London, and others working to build a tech and innovation pipeline for the COVID-19 pandemic. And we'll be hearing today from a number of COVID Action partners, including the Global Partnership for Sustainable Development Data, the COVID-19 Vaccine Equity Project, FRAME, Surga Ventures, and Sabin Vaccine Institute. And I will be facilitating a panel discussion later with FCDO, International Medical Corps, WHO, COVAX, and UNICEF to help synthesize some of the conversation into action points. And action everyone is the point of this call at the end of the day. And I'm really delighted to say that by being here, we are participating in the launch of a new impact fund and an open call for applications via the Vaccine Data Collab, focused on solutions supporting vaccine prioritization, planning, and rollout across low and medium income countries. Our friends at FCDO and COVID Action have shown a great deal of leadership in bringing this to life. And I would now be happy to turn it over to our colleague, Michael Klein of IMC, to share a bit more context and to kick off the program. Mike.
Wonderful. Thanks so much, Lance. And I think you kind of sketched out the need and the priorities, globally speaking, really well. And just to kind of jump right into the agenda for today and what we'll be covering specifically, as we discussed between NetHope and GPSCD as well as ourselves, this particular meeting, we looked at what's the best way to hold this conversation, and picked up on really 3 different themes, key themes that we wanted to address today. The first of which is the actual data gaps that currently exist across low and middle income countries as it pertains to vaccine prioritization. And in the research that we've commissioned as part of COVID Action, as well as the partners and conversations we've had, we've got a great lineup for you today in GPSCD as well as the Vaccine Equity Project to be able to sketch out what some of these data gaps as it specifically pertains to vaccine prioritization look like. The second bucket that we have is tech and data solutions. So these are providers that are looking at addressing these data gaps and working alongside governments to be able to put forth solutions that address these needs. And then lastly, we wanted to kind of open up that conversation. And we have a what I think of as an all-star panel that we have that will be moderated by Lance to kind of bring that conversation to life. Do we see these data gaps and some of this emergent research really meshing well with some of the data and tech tools that we're servicing today? And hear from practitioners in the field around how this actually plays out. Before we get there, let me jump into a little bit about COVID Action and kind of how we, as COVID Action and FCDO, have been responding to COVID-19 and really our journey to date to this call. So COVID Action is about a year old now. We started early on in the pandemic, thinking about kind of the innovative tools that could support response to COVID-19. And since that time, we've launched 4 separate calls. Started with an oxygen call, actually for ventilators, and then moved on to a call for data tools, looking at also things such as local production, local solutions, items like PPE and how that could be produced locally. And finally, resilient health systems. And so these are the 4 calls that we put out into the world over the past year. And you'll see that we've made awards and created portfolios of tools and investments as COVID Action. And the idea is to do some sense making, really highlight what we see as best in class investments. And specifically to the data theme, that's what we did. So we've been now running for about a year and have made 12 investments which cut across the data lifecycle. And these 12 investments look at items such as data collection tools, data prioritization tools around risk and vulnerability data, and looking at data use and partnering with organizations like GPSTD. And if we can go to the next slide, where has that taken us? That now has taken us to a point where a lot of from the data challenge perspective and the awards that we made via that portfolio has taken us to the point where these data innovators have moved really aggressively to supporting LMICs as it pertains to vaccine prioritization. So looking at some of our portfolio of 12 innovators, here's 3 of our COVID Action Data Challenge partners that have moved into this space, and of which you'll get to hear from today. So Surga Ventures being one, working alongside Ministry of Health in China and Nigeria, looking at vaccine prioritization planning with data tools. Frame, working in Pakistan along UNDP WHO in that country, as well as select other countries as well, expanding some of their work using data tools using machine learning and others to make GIS-related data available for vaccine prioritization. And then finally, GPSTD, one of our partners since the very beginning, really listening to local organizations, national statistics offices, and others around what their data needs are as we surface some of these tools to put them in the right hands. Next slide, please. And along the way, working in the vaccine prioritization space, we've made some friends. So WHO in particular and the GIS working group, which you'll get to hear from later today, we've made sure that some of the investments that we've taken on and work that we have supported as COVID action early on is foundational. So we're building on the data and tools and systems, which can then lead on to A, micro planning later on, actual vaccine campaigns, but B, healthier data ecosystems later on. So we want to make sure that the investments we make today are coordinated both with local programs and NGOs, NetHope membership, as well as the international architecture that to ensure that some of these investments in Surgo, in Frame, and all of our other partners do have continuity and as well as sustainability down the line. Next slide, please. So, in that context, and this is the exciting part, we've had lots of conversations around data needs. And we've come to kind of the shared consensus as a group that we want to hear what the types of tools and solutions are needed locally that do interface well with existing programs, needs of NSOs and governments, as well as ministries of health, NITAGs, and what are those data tools that people are looking for right now that we can help provide catalytic funding towards. And the conversations we've had with other funders, as well as within FCDO, has been, let's create that portfolio, that clearinghouse, and make these opportunities available to a wide group of individuals. So I'm happy to have our COVAX colleagues with the GIS working group here as well that we'll be able to share some of these applications with. FCDO as well will be able to be funding some of these applications. But really centrally and kind of core to this open call, which will provide you a link to some more information later, is an ability to kind of raise your hand if you are a technical partner, a data partner, an NGO with that established relationship with a government, to be able to say, I think we can do some good here in terms of supporting foundational data needs that get us to the point where we're creating kind of sustained and long-term growth in closing data gaps. Next slide, please. So to that point, and at the outset, I talked about kind of the three buckets that we have. The three buckets, we're moving first into kind of the research. Before we kind of open up this fund and talk a little bit more about that at the very end, but first we want to be really clear about what the problem statement is and hear about some of the emerging research that's taken place across low and middle income countries that really kind of raise the profile of needs that we're looking to address. So we have a couple of speakers that we have here for you talking about some of this emerging research and findings, GPSTD, as well as the Vaccine Equity Project. And with that, I get to turn over to our first colleague who has been doing some early research on the subject with GPSTD, which is Victor Ohorogu. And Victor, over to you.
Yeah, thank you very much, Mike, for having me. Allow me to switch off my video as well because of bandwidth issues, but just to show my face and to, smile at the audience. I'm really happy presenting this on behalf of the Global Partnership for Sustainable Development Data. The GPSDD, as are commonly known, was established in 2015 and is housed within the UN Foundation. And our aim is to help work with stakeholders across countries and sectors to fully harness the data revolution for sustainable development. Just to provide some context, last year when the COVID pandemic broke out, we collaborated with the UN Economic Commission for Africa to reach out to 54 countries in Africa. We did identify needs and priorities across 50 of these countries. We had deep level technical conversations in 35 countries and also brokered over 34 partnerships in 19 countries, and we're still counting. And sometime in February and early March of 2021, we again worked with Geospatial and the UNECA to run a COVID-19 perception survey in 8 countries with the outcome aimed at supporting effective policies and campaigns that will encourage vaccine uptake. Then in early March, as we saw several countries in Africa started receiving and distributing their first batch of the COVAX facilitated vaccines, we quickly observed that many of them were being challenged regarding the effective planning, prioritization, and equitable distribution of the vaccines. So, of course, Frontiers Technology Hub and the FCDO did ask us to undertake a rapid assessment across 8 countries. Next slide, and you can see the map on this next slide. And the deal was for us to quickly understand what mechanisms are being used, as well as the capacity gaps, so as to be able to possibly match these opportunities with support from Frontiers Technology Hub and its partners. And so we anchored our country's engagement approach on the strong relationship we already have with several of the countries across Africa and the relationships that we've also developed. So we reached out to the UNECA African Center for Statistics to have connection to Africa CDC. We did also outreach a number of UN resident coordinators in a few of these countries to identify focal points, around this vaccine distribution agenda. We did directly also locate a number of those relevant agencies and departments of the MOH within each of these countries, and had several communications and engagements with the focal point to help them understand the objective of the survey, secure their permission, agree on the preferred information capture method, whether it was electronic survey via SurveyMonkey or conducting key in-depth interviews with these focal points. Next slide, please. And here are a few of the findings from our engagement across the countries that we surveyed. It is interesting to note that the politics of health data and information have been further worsened or deepened by COVID pandemic, given the huge mistrust between many of the political parties across these countries, and of course among the various government institutions in many of the countries. As a result of the political handling of the pandemic, we had cases of allegations of mismanagement of COVID-19 relief funds and the PPEs. And moreover, obtaining information from the ministries of health in many of these countries require a good amount of time needed to have several levels of engagement, go through several bureaucratic approval processes as well. And thirdly, many of the stakeholders and the focal points we engaged who provided us data and information noted that the assessment timing was quite inconvenient for them. And finally, also, the confidentiality requirements, given the highly sensitive nature of the health sector activities, information and decisions, and more importantly, the pandemic response in itself made it quite difficult for several other respondents to share information with us. But some very quick highlights from Ghana and Rwanda, 2 of the very beautiful countries that had super engagement with us and gave us sufficient data and information. Next slide, please. So in terms of the unavailable national coordination mechanisms, we did discover that across most countries, there is a coordinating mechanisms, which oftentimes has 2 layers. In Ghana, the top layer was a presidential task force that comprised of several of the key ministers, technical partners, diplomats, and then you have the second level, which was a technical working group, which was at that point, of course, till now, being coordinated by the Director General of the Ghana Health Service. The National COVID-19 Vaccination Coordination Mechanism actually leveraged the existing national coordination mechanism and technically includes the routine vaccination planning and deployment mechanism that they currently had in the country. Ghana's rollout plan was rated A+ by the WHO. It was developed using the WHO and UNICEF guidelines with a lot of support from the Immunization Technical Advisory Group. And in Rwanda, they have a national task force on COVID-19, which is chaired by the Minister of State for Health. And this reports into the Prime Minister's office, while the technical organ is led by the Rwanda Biomedical Center, traditionally leads on all immunization and vaccine efforts in the country. These two countries also have very robust national deployment and vaccination plan, which they did pretty much adapted from WHO and UNICEF guidelines. And in terms of the vaccine prioritization and the data that was used to prioritize, and plan, both processes in Ghana and Rwanda pretty much leveraged the National Immunization and Technical Advisory Group. In Ghana, they were quite careful about the word priority groups because of the political sensitivity of that word. And so they decided to use population segmentation rather than saying priority groups. And they had, citizens 60 years and above, frontline healthcare workers, citizens with comorbidities, frontline security agencies. And data was used to a very large extent, disaggregated to the lowest administrative level, which is the district level in Ghana. And in Rwanda, they, of course, had their own prioritization using data at every point in time. People 65 years and above, frontline healthcare workers, people high risk, police, military, airline workers, etc. And of course, they did say that the entire prioritization and deployment process was all data driven. And the focal points, made a statement, and I quote, "You don't have a say if you don't have data." And so data is key to everything that they did. And they have data disaggregated to the lowest administrative level, which is the village in Rwanda. Finally, in terms of capacity, infrastructure, and other gaps, a number of things came up from across a number of these countries. Inadequate quantity of hardware for collecting data. They had inadequate number of staff for data capture. Some sites had electricity challenges to deliver power to the data collection devices. They had limited internet connectivity as well. On the data side, some agencies were using population estimates rather than actuals, which could lead to potential gaps in up-to-date information on target populations. They also have insufficient data in some places on the vaccine sites. And of course, across all the countries, not enough vaccine was mentioned as a major challenge. And so in terms of the interest in considering the various decision support tools that were developed by Frontier Tech and its partners, the two countries said that they were very much willing to take a look at those tools and to see how they can apply those tools if we bring them across to them. So this is just a quick summary of the survey. I'm sure more details are contained in the report, which is being published by Frontier Tech and the GPSDD. I'll now pass the stage on to Jen Florida of the Sabin Vaccine Institute to speak to their vaccine equity project. Thank you very much.
Thank you, Victor. So in my role at Sabin Vaccine Institute, I oversee our Boost community, which is a network of over 1,300 immunization staff from 130 countries around the world. We focus on supporting our community, which is mainly representatives from low and middle income countries, with foundational learning opportunities on leadership, management, community building, really fostering peer-to-peer connections, and working closely with partners to bring kind of the technical lens into our work. A theme that really began to arise within the Boost community late last spring, early summer, as we were talking about rolling out the COVID-19 vaccine, and we were still in the mode of, will we get vaccines, was really a concern around what will national equity look like in COVID vaccine rollout. So not just kind of global equity, but national level equity. And we really started to look at, and folks were talking about what the challenges would be at a country level, at a community level, at that last mile. And given many low and middle income countries do not have life course vaccination programs, they don't have kind of the mechanisms in place to reach the adult populations that would be prioritized. And in addition, some of those most in need are, yes, in the hardest to reach areas where getting vaccines to them will be really extremely difficult. So in response to this, Sabin Vaccine Institute, JSI, and Dahlberg launched our COVID-19 Vaccine Equity Project, or CVEP, yet another acronym, in October of last year. And we worked with our Boost community of over 1,300 members to really understand, when we're looking at national level equity, what should the core priorities be? And so with that, the 5 core focal areas that came out were: 1, transparent data-driven approaches to identify, reach, and track vaccine recipients; 2, effective and inclusive planning and coordination to reach priority populations; 3, equitable and data-driven immunization supply and cold chain management and design, 4, healthcare worker and community health worker engagement and training, and then 5, community engagement, mobilization, demand generation, and acceptance. I'm now appreciating that I should probably have thrown a slide up there for this. Happy to share these out or share our website afterwards. You know, it's interesting because within those themes, of course, to explicitly highlight data, but underlying all of them is the importance and relevance and need for data. Victor, I think you said data is the key to everything, and we feel similarly, and I think that's what we're hearing from our community as well. So we're working with our Boost community and our CVAP initiative to find ways to support community members across the 5 areas I mentioned. And I'm really excited this morning, this afternoon, this evening, depending on where you are. I know our first speaker on our end is, it's very late for her in Nepal, but I'm glad to introduce 2 Boost community members who will be speaking about their experiences within Nepal and Nigeria, respectively, about COVID-19 rollout for their countries and how data is really playing a role. So I'll first introduce Leela Kanal, who's joining us this morning, or late this evening for you, Leela, in her role as a technical lead for our CVAP work in Nepal. And Leela has over 28 years of experience working with UN and international agencies, leading and managing public health programs. And so Leela, I will pass it off to you.
Am I audible?
Yes, you are now.
Thank you. Thank you for this great opportunities. And I just wanted to, I'll take this slide. I try talking about it, but I'll like to tell a story, how we started our journey and what was the problem it came, and, you know, and how we solved the involving the government, professional and expert, where we are and where we want to go next. Next slide, please. And basically, and it was very necessary to, you know, give information and to the all level why national COVID vaccine register is necessary. And because I just wanted to tell you, vaccination service was never digitalized in Nepal. Of course, there was information reporting was there. There used to be digital reporting, not but not like an individual line listing data where we can see the, you know, gender, ethnicity, caste, and advantage and disadvantage, mountain, hill, and terrain. Those detail was not. And in the system, we just could see the aggregated how many children or how many people has been vaccinated in the system by province or district. And first things, and what we did is, basically most of time, and we used to have a paper-based vaccination registration system, and even children used to get a vaccination card after immunization, and the retention was very, very poor. And because of the quality of the low quality of the paper, proper communication, and hard to follow. And because of that, and it sometimes even hard to follow up the baby has been fully immunized or not. And because that's sometimes the mother, you know, recall might be biased, they could not remember all the things, and there are language barriers, there are lots of other hazards. And that's what we realized, that this COVID vaccine is the opportunity to have all line list information, and it will be the whole data set of the populations above 18 years. And even that will be opportunity to us to know how many, you know, cadre of health worker, how many actually female community health volunteer, and all those details we could find from that. And initially, there was opportunity, like when COVID came to Nepal, and there was a program called IMU, information integrated management information management system was introduced to track the COVID cases, and to follow up them. And later on that, we use the same platform and to use the COVID vaccines data. And we have a window of opportunity to pilot with this. Thank you to the CPAP project. And we could develop an app, and we could pretest and pretest in the pilot in the one municipality. And so far 400,000 data has been, line listing data has been already collected. And that is the online self registration form. And people get a unique ID number with that one. And then sometimes if you cannot do the self also, that's assisted also is there's the opportunity for the assisted also online registration, and to get a unique ID. And if there's one or two option is not available, and if there is no kind of if there is no internet, or people still have a opportunity to go for the paper base, and they can do, whenever the health worker have internet, they can do the offline, and whenever the internet comes, it goes to the offline. And that is a good thing. Is now, it used to be initially when there was IME system, it was kind of more project lead, and it was not government buy-in was issued. And now after that, it was already linked with the SMIS, and that database has been already created. And sometimes what you can do, if you can't do the online registration also, you can work in the clients and paper-based registration, because one main motto with that self-registration or online registration should not restrict the people to get the vaccination. That's what digitalization is important. At the same time, there was always conflict between program people and program people and data people. Program people said, this is my target, I need to achieve the whole, and data said, okay, you need to have a, ITs, you need to have a unique ID. ITs is important, but for the program people, they just need it to achieve the target. But their target is how many people get vaccinated. They need all those things. And so what we did, next slide, please.
And sorry, Lila, I know we only have, I think there's about 30 more seconds for you. Sorry about that.
I know. I'll try to. And with what we did, we have we did in the one pilot in one area, and we shared that pilot result with the high level government, UNICEF, WHO, UNDP, GIZ, and UNICEF to work together. Now government has already endorsed the idea of digitalization, and this joint work plan has been developed to scale up the digitalization nationwide. And there has been already developed budget and identified the budget gap, and even the partners have committed what part they can support and what is the needed gap. And basically we are optimistic that it will be scale up. The pilot we have done will be scale up national level, but definitely there are resource gaps, and it will be fulfilled soon. Next, please. I'll finish soon. Maybe I'm done.
Thank you so much, Leela. And real quick, just wanted to, we don't have a ton of time for you out of here, but really want to hear from you as well. Out of here, Abu Bakar is a Boost community member joining us from Kaduna, Nigeria, where he works as a technical assistant for the National Primary Healthcare Development Agency. So out of here, I think we have about 2 minutes, but would love to hear your perspective on how data has played a role in your work.
Okay, thank you very much. Good morning, good afternoon, good evening, depending where you are. In Nigeria, we use these two systems to distribute vaccine using target population. There is a micro census that was conducted in facilities, and secondly, people register online. So using that two sources, we were able to determine the target population for vaccination. People can use the internet to register, and data has been collected centrally using the real-time reporting on the DHIS2. So that's the source of collecting the data and transmitting it to the national server, in which the national will look at the data and analyze how many have been vaccinated. Though there are some challenges here and there with the server, because it's based on internet connectivity. Some areas you don't have internet, so it's difficult to transmit data via real time. So sometimes it will take like 2 to 3 days before it can be uploaded. Those are some of the challenges. Which definitely the target population was able to was determined appropriately, as I mentioned earlier. People were immunized based on the target population sense. So certain population were though excluded a little bit. The people with disability, where they were able to, they were captured in some part of the country, but other part were not captured. Then lastly, after immunization, the data, as I mentioned, data has been transmitted centrally to a card is being issued to the vaccinator. The person who has been vaccinated, in which you will keep that card, so that for the second visit, he's going to come along with the card, and there's a barcode on the card which can be scanned to prove that he was being immunized in the facility, so that people will not be moving from facility A to facility B, or from county office to county, in order to cause shortage based on the target population. So those are the areas that we use in country in order to capture our data of the vaccine. Thank you very much.
Great. Thank you so much, Adi here and Leila. And I would just like to comment as well. We have, you've generated a lot of interest in the chat. So I think there's some questions that are directly targeted to you there. And if you can hop into the chat, I think we can kind of continue that dialogue. There's questions there. If you just back to the person and kind of address some of those questions, that would be wonderful. But kind of hearing what we just heard around kind of the research gaps from GPSDD, as well as from the Boost community, I think there is a wide diversity of the types of challenges that are faced. And that's clear both from the research as well as from the presentations that we've heard. It kind of underscores this, there's no one size fits all approach to kind of leveraging these data tools. And really, I think we need to be able to meet where the needs are within governments, NSOs, NGOs, and others that are undertaking programming in this space. I don't think that the type of global tooling that we're looking at addresses all the different issues picked up on by Leila, Adi here, as well as Victor. And kind of to that point, I think our next section, which is going to be touching on the tech and data solutions and a lightning talk round, will kind of give you some appreciation for what are the types of tools that are being used to help facilitate prioritization and use of data tools to address some of these kind of thorny issues that we just heard about. So, with that, it's really heartening that a couple of these presenters are grantees that we've been working with now from the COVID Action FCDO perspective for about a year now. And so we'll get to hear from them. But in addition to that, we also get to hear from, again, from Saban Institute and their PriorityVax tool. So without further ado, let me go ahead and kick over to Carmen Tedesco over at Frame, talking about using geospatial data to look at vaccine equity models, which can be used in the prioritization process. Carmen, over to you.
Thanks, Mike. So I am Carmen Tedesco. I am Deputy Director for Analytics at Frame. And at Frame, we work with governments and organizations to build data sets and analytical products that provide local level insight on livelihoods, demographics, attitudes and behaviors, health, and public service areas. So we all know that data on people and places are always a challenge. And we really work to solve some of these foundational data gaps in sociodemographic information in places that are data poor around the world. So go ahead, Kelly. the way that Frame works on this is we collect and acquire all kinds of nationally representative surveys, partner surveys and data, and also satellite imagery. We then bring all this data together and harmonize it, clean it, make it usable, make sure it's geospatially enabled. And then we have our own proprietary algorithms and models that we are using to create layers and surfaces of interpolated data down to the really hyperlocal level at 1 square kilometer. And then from there, we can do all kinds of analysis to look at answering different questions that arise based on whatever the particular need is. So about a year ago, we began modeling COVID risk through developing layers of indicators related to that risk, and then also building out vulnerability indices for a variety of COVID factors. More recently, we've pivoted to also look at modeling the equitable distribution of vaccines around the world. And we also just joined the COVAX GIS working group. So we're getting more insights into the work that's being done around this topic globally. So we're able to map the data, like I mentioned, to that 1 square kilometer level that really allows us to highlight the spatial distribution of these priority groups. And this is determined based on the context and priorities identified by government policies and by stakeholders that are on the ground. And this might include things like the vaccine supply and the type, epidemiological settings, the case data itself, and the beliefs and attitudes and values of the population. So we can then classify individuals within priority groups using a customized index of vulnerability. And we can weight different indicators based on categories of vulnerability. And some of those include things like the exposure risk, comorbidities, information access, vaccination likeliness, and just COVID prevention in general. And then we identify communities that have both high risk and then also high numbers of people in those priority groups. And then that is how we target for decision making and planning. And so far, we've applied this model to Pakistan, Nepal, Ghana, Mali, Kenya, and Guatemala. So you can go ahead, Kelly. Our model is built on the WHO SAGE guidelines, and it's informed by each country's vaccine supply coverage and priority population. So this is the framework that we use when we start any of our new initiatives in a different country. We first gather this information, figure out where we are in that particular country's stage and their priorities, and then that's what we use to start our planning. So we use different methods to get our data into the hands of decision makers. And for this work, we're using a data visualization platform that we've built that's called DataFrame, and it allows users to explore the data and do some really basic analytics, even without any GIS training or experience. And in this case, the example that I have here, we're looking at the Pakistan data that I just mentioned and exploring the layer that you're looking at is the combination of high priority and high vulnerability. And then I zoomed into a particular city to look at indicators for a specific grid cell, which is the one that's highlighted, and that's the 1 square kilometer. And then you pop out all the indicators that are available that I've selected within that particular grid cell, and you can see there's community vulnerability score and then other related indicators. And this really allows the decision makers easy access to the data that they need. So Frame's geospatial insight is flexible, and it can further model vaccine hesitancy, health misinformation, and downstream effects of the pandemic. And all of our models map where priority populations are, what their vulnerabilities are, who should be prioritized among them. And then we use existing data and proven methods to do this with this enhanced machine learning modeling that I talked about earlier. And then lastly, they're all adapted to that unique context of each country and population. So if you have any questions, please feel free to reach out. Here's my contact information. I'm happy to share more about what we've done. Oh, sorry. And over to you, Rahul, from Surga Ventures to talk about what they're working on in Nigeria.
Thank you so much, Carmen. Am I audible? Great.
Perfectly.
Thanks for that. It's a pleasure to meet you all virtually. My name is Rahul, and I represent Surga Ventures. Next slide. For those of you who may not be familiar, Surga Ventures is a nonprofit that's based out of Washington, D.C., though our team is spread all across the globe. We started a journey about 5 years ago with the intent of bringing precision to global health. And we do that by bringing together the best of behavioral science and data science. Over the past year, we've developed a broad portfolio to support the COVID response. This includes tools to identify vulnerable populations, to understand vaccine hesitancy, and also to deliver personalized health information via a free hotline. The focus of this presentation is on our work in trying to understand and support the vaccine allocation in Nigeria, where the supply is quite frankly limited. The country received its first batch of doses last month, but it's nowhere near enough to vaccinate the entire population. In this context, as in many other speakers have mentioned, prioritization is critical. Defining who should get the vaccine is only half the battle, but figuring out where they're located and how many doses should be allocated in each region is just as important. Next slide. To meet this challenge, we're partnering with the Clinton Health Access Initiative to develop a simple tool that can bring precision to the rollout. We use data and analytics to estimate the required doses in each state for priority groups. For now, we're focused on healthcare workers and adults above the age of 50. It also gives policymakers an option to focus allocation on vulnerable communities and plan ahead for distribution. Next slide. This tool was developed in Excel because that's familiar to most people, can be accessed without internet. It also allows us to rapidly modify it as the situation changes on the ground. Users can specify the total number of available doses. They can indicate a split between doses and priority groups. And they also have the option of redistributing doses based on a vulnerability measure. So for example, they could decide to set aside 10% of their doses to the most vulnerable communities if you look at socioeconomic factors, for example. The tool generates a list of estimates. It shows you the total doses that each priority group should receive, what percentage of each priority group is vaccinated as a result, and also provides a breakdown by state. In the screenshot on the left, you also see how vulnerability is considered in the estimation. To arrive at these estimates, we leverage spatial data and the latest research on comorbidities and in their prevalence. I won't go into too much detail, but just at a high level, we identified publicly managed facilities to estimate healthcare workers. We looked at the comorbidity prevalence, considering overlaps by age groups, and then extracted precise population counts for these priority groups per state. These estimates can be made more granular, and we could go down to the level of the LGA if required, but we've kept it at the state for now. Next slide. In addition, we use the Africa CCVI to assess vulnerability along 7 key themes as laid out on the slide. The government can choose to pick any one depending on their priorities. So for example, you might consider redistributing doses to regions that have high population density, where you might expect more spread of the pandemic or the virus. Next slide. Oops. Right. Getting vaccines to those who need it the most is a complex and fraught process. I heard from one of our speakers that Nigeria is going to be registering everyone through an online portal. But before we get there, we need to plan ahead. And this information can be used to ensure supply chain readiness on the one hand. So figuring out how to get doses transported safely and on time, but it can also be used to build community acceptance. So disseminating information around availability and eligibility through the channels that people use the most. We're currently rolling out this prototype to key users and the government for testing, and we'll update it based on their feedback and guidance. And depending on the interest, we may add data and build this out into a full-fledged dashboard and make it available online. Thank you. That's all from my side. Just to add, we're looking to scale and expand the use of this tool and potentially replicate in other countries. But of course, we can't do it alone. So if you'd like to collaborate with us, please do reach out. You can access more information on our website, which is precisionforcovid.org, and you can see more details on the other work that I mentioned at the start of this presentation. Thank you so much for your time. And with that, I'll hand over to Ben from the Sabin Vaccine Institute.
Thank you. So my name is Ben McCormick. I'm a consultant at the Sabin Vaccine Institute. I'm going to give a very quick introduction to Priorityvax, which is an online flexible tool for prioritization decisions. And the way we've presented this is we're going to do a little video, and that means you can see some of the dynamic elements while I'm still talking. So if you can hit the video. This platform is built on 3 core values. The first of which is to promote sustainable decision making. That sustainability is multifaceted, and Priorityvax is a tool that is meant to capture these different, often competing demands on systems that are already constrained. The second point is that Priorityvax has to be accessible to any decision maker, advisory group, or indeed different stakeholders. Evidence might come in many point is that Priorityvax has to be accessible to any decision maker, advisory group, or indeed different stakeholders. Evidence might come in many different formats. Priorityvax is designed to utilize whatever information is available so that the decision is grounded in the local context. This is important because this local context means that there are more appropriate decisions for health that address local drivers of equity and help to promote local ownership. Last, Priorityvax facilitates a transparent process. Priority setting is a balancing act, and Priorityvax promotes capturing implicit values and making them explicit. It supports the use of evidence, including citations and referencing of sources, and it can be used interactively to demonstrate the deliberative process. In the end, it can generate a standardized, shareable report that can be combined with a more detailed narrative to show how evidence was used. The tool is built to be user-friendly. It's online and accessible from any web-enabled device, using simple buttons and sliders to navigate and enter evidence. The robust methodology behind Priorityvax can accommodate a wide range of scenarios, pretty much any prioritization process you can describe. And to that end, Priorityvax is flexible and customizable to your needs. If you had a particular decision-making process, for example, then Priorityvax can facilitate discussions with interactive results to probe the sensitivity of subjective weights. Or you might use it interactively to explore the implications of uncertainty, for example, in published values, or evidence from different studies, or the confidence intervals around data. You might want to adapt an existing decision-making framework to accommodate different factors. And you almost certainly want to share the outputs with other stakeholders. The readouts from Priorityvax are easily annotated and can be shared to give an audit trail from evidence to recommendation. Within the COVID-19 Vaccine Equity Project, Priorityvax is being used to explore several challenges. The most obvious is a prioritization between different risk groups. For example, looking at adaptation and implementation of the WHO roadmap. In this example, we took the early qualitative data from the WHO SAGE committee to try to look at prioritization of groups based on risk. With new evidence emerging all the time, and the epidemiological situation changing in many countries, these analyses can be rapidly revisited and updated to accommodate new evidence. The second is then to ask where those risk groups are within a country. Having identified who gets the vaccine first, the challenges of rolling out a vaccine campaign hinge on getting it to the right places and overcoming barriers of equity. A really exciting development has been the Surga Index on COVID vulnerability. One of the principal challenges to any decision makers just now is the lack of information. But the absence of data doesn't make the decision go away. Fortunately, Priorityvax can accommodate different types of information, including qualitative scales, that could be revised and updated as data become clearer. But it also takes information, for example, from the Surga group, that explicitly address issues that might not normally be quantified. In this example, to address issues of subnational allocation, we populated the model with some data dimensions from Surga to evidence issues of equity. These can supplement more quantifiable measures of, for example, current disease burden, the population density, to get a sense of where populations are at greatest need. The third example might be increasingly important as new vaccines reach the end of their clinical trials and become available. And that's to consider the alignment between vaccine characteristics and local requirements. For completeness, we would also add that Priorityvax has previously been used to examine the introduction of new vaccines within context of health needs. And as the pandemic wears on, this might become more of an issue later as the broader question of how vaccine decisions are made.
Thanks. So I would just end by saying that the Sabin Vaccine Institute is trying to actively engage with the transparent and equitable distribution of vaccines. And with Priorityvax, we're trying to do this in three main ways. So the first is the identification and engagement with decision makers and stakeholders at different levels of decision making. So for example, regional, national, and subnational. The second is to see how Priorityvax as a platform can integrate into existing decision-making frameworks, in particular evidence to recommendation frameworks. And the third is to facilitate the use of Priorityvax, whether that's in person or remotely. It's designed as an easy and flexible tool, so it's easy to implement and adapt to different needs, but it is within a context which can be more complex of evidence to recommendation frameworks and how you use data. Thank you. I look forward to your questions and comments.
Great. And thanks so much for that, Ben, as well as Carmen and Rahul. I think that those lightning talks really brought home, I think, some of the points we heard previously around the data gaps and really how we are addressing those specific data gaps. One thing that came out, I think, really clearly from the Priorityvax presentation, at least to me, was it's one thing to set a priority or prioritize a group, and it's yet another to be able to actually have the data to understand how many individuals, where are these individuals located, to be able to prioritize vaccine allocation to those groups. And that's where the kind of foundational data sets are needed to be able to drive this conversation. Without knowing where, for example, individuals with disabilities are, where there's more prevalence for those groups within specific communities or within a country, we can't take action to be able to prioritize vaccine in the numbers that may be needed to be able to address that need. So anyways, thank you very much to our lightning talk presenters. And now we have the opportunity to hear some Q&A to actually talk to our lightning talk presenters as well as to our researchers that talked about the data gaps earlier. And I will kick over to Diana as well as to Kelly to go ahead and address some of the Q&A that have been coming through in earnest in the chat.
Excellent. So I'm going to start with just saying at the top of the hour that you will get the contact details of the presenters because there's a bunch of folks that are just like, I need to talk to that person. So we will make sure that that happens. But actually, I thought there was one right at the end here, which I thought is a great place to start. So Diego, do you want to ask your question? You're somewhere here, I think. You were addressing a question to Rahul, or Rahul, maybe if you've read the question, you can answer then. It was about hesitancy in frontline workers.
Yes, absolutely. I was just typing a response to him in the chat. So Diego asked about, the changing realities on the ground and the fact that, sometimes healthcare workers may be hesitant and we may not be able to vaccinate all of those who have been prioritized. And instead, we might have to prioritize people who are less hesitant, but lower priority, such as strategic populations. And I completely agree. And one of the things that we want to do is to be flexible to meet these changing requirements. So if it's a different population or other types of essential health workers, like, the police force, we'll work with the government to estimate those people as well. We may not have publicly available data to, create those estimates always, but I'm sure the government can help us with some guidance in that respect. But if you were to prioritize, say, adults between the ages of 30 and 40 with comorbidities, for example, or younger and less hesitant, that's something that we could estimate with the data that we have at hand. So I completely agree that there is a need to be flexible, and that's part of the reason why we created something in Excel to start with.
Thanks,
And
Rahul.
then that's great. And then there's one more question, which I think we can kind of aggregate, which is possibly to Leela. There have been quite a few questions about women, for example, and how that factors into some of the stuff. I believe there was a specific question from Stephanie on this. Yeah.
Okay. What is the question? Would you like to say what was the questions?
Stephanie, would you like to ask your question? Are you there? You're good. I'll ask Stephanie's question for her. It was, how is the data from national registries available to be used? Is this publicly available? And then there were other questions about, on the women's side, it was that women are often disproportionately impacted, that kind of thing.
Yeah, basically this online registration was available for everyone, and everyone can register using their mobile device or computer. And even I mentioned that, and even their family member or children can assist to the other whole family member, and who can digitally literate. And another thing, if they can't do the pre-registration, they can walk to the vaccination site and take and health worker can registration help assist registration over there in the vaccination sites. Sometimes if there is no internet in the vaccination sites, and the record will be in the paper, and after vaccination sites, and vaccinator will enter those data, and whenever internet is available, that will be uploaded. That's the current pilot project we did.
That's great. Thank you.
And especially, okay, especially for the women's, your questions about the women's, and that basically there was not much differentiated, and there was not issue we found during our pilot project, because their children were helping most of the time.
Oh, that's
great. Penny, we had a question from you on disability. Do you want to go ahead and read out your question quickly, and then we're going to move on to the next round, but we'll take this last question.
Yes, thank you. So I'm Penny Innes, head of the Disability Inclusion Team at FCDO, and we know that people with disabilities have been particularly affected by COVID-19, partly because of health issues, but also because they're particularly at risk because of reliance on touch or reliance on carers, or they're living in institutional settings. And so I suppose my worry is that they might be identified for vaccination, but are the national systems going to be disability inclusive, so that, for example, communications about vaccines are accessible, and the process actually to get a vaccine is accessible? I'm just interested if anyone's looking at the extent to which preparations are factoring that in. Thank you.
And that is a great question. Thank you so much. And we're having questions like we are revising all those equity questions, because as I mentioned before, it was kind of piloted. Now government has already decided to scale up nationally. Tomorrow there will be the indicator finalization meeting will be tomorrow. And we have not included disability questions, so indicators so far, but definitely that is the feedback for us. We'll try to include that one. And especially for the disability, there are a particular, every rural municipality, and there is a disability wings, and there is a team. Most of the time, every disability, they have the disability card. Based on those cards, they get other facility, and even they get some government incentive kind of they have kind of some support from the government, monthly financial support, disability support. And we basically the same card used to identify the disability, but I'll make sure this is happening, and we are having a meeting tomorrow and make sure it will be included. Thank you. Any more questions from me?
We're good. Thank you very much. I think we're going to move on to the next section. And Lance, we're turning over to you.
Great. Thank you, everyone. And I will apologize in advance. Zoom being the world that we live in, the folks on the street have chosen this day to do some street work. So I'll try to mute if there are jackhammers and other things appearing in the background. So apologies in advance for that. But what a great discussion. This was a really interesting look kind of around the world of challenges, but opportunities also on this particular question. You know, we heard, and I think we heard sort of the whole spectrum expressed in that previous section. We heard about the need to go from all the way down to the root of the problem in the communities, how we can push things like registration down to community level, data capture down to community level, and then we also heard it from the top down. How can we have a national registry? How can we actually work from the ministry level to provide that? We heard from Frame about the critical applicability of geospatial data in helping map some of this, technologies that were just simply not available not so long ago. Surga talked about the idea of allocation planning because supply in many countries is going to be limited. So how can we allocate supply effectively? And Sabin talked about prioritization in that limited supply. How do you weigh those trade-offs in a way that's effective? And perhaps data provided by Frame and others could be a way of doing that. So, kind of around the world view of all the different things that we're grappling with here. And this panel is really about bringing it all together. And I'm delighted to say we have a really wonderful panel of experts to share some of this information. We have from NetHope member International Medical Corps, Dr. Javed Ali. From FCDO, we have Dr. Emi Chirchir, and I'm really pleased to note that FCDO has been at all 3 of the NetHope COVID vaccine data calls to date, and we appreciate their participation and interest in our work. We also have Siobhan Green from IMC Worldwide, Ravi Shankar Santana Gopalakrishnan from WHO and COVAX, and we have Rocco Panciera from UNICEF. And what I'll do is I'll pose a couple of questions to the panelists. I'll ask them to give just a brief introduction of their background and work, and then we'll when they speak, and then we'll jump right into to responses. And so I think one of the places that seems like it's a good place to start is that nexus of both limitations as well as opportunities. And I think we had a very good statement of some of the limitations in one of those early slides from the COVID-19 Vaccine Equity Project. You know, politics, access to information is complex and political. There's bureaucracy. We've got information sharing, which takes time. And then there's the cost of engaging at all the levels required. There's resourcing. Many of these organizations that are involved in delivery just simply do not have additional time to do things beyond their core work and then the 2 or 3 tasks that they're already doing on top of their core work. And of course, we have confidentiality concerns, and that it works everywhere from policy all the way down to the ability of data to be seen and shared by people who both need it and who may also not have authorization to view it. So lots of limitations, lots of challenges, but there's also tremendous opportunity here because as we've seen, there's some extraordinary solutions on the table. So I'm going to ask the panelists to speak a little bit to both limitations and opportunity. And Dr. Javed, why don't we start with you? What's the view of International Medical Corps on this landscape that we're working in?
All right, let me start. Hi, good morning and good afternoon, everybody. My name is Javed, as Lance mentioned. I'm a physician by background. I've been working with International Medical Corps for quite a while now as the Director of Emergency Response. And with that, I was leading on the organization's response, and particularly in Africa and in Middle East for COVID-19. So Lance, that's a simple question as well as a complicated question, but I'll try to sum it up and I'll then pass it over to my more learned esteemed colleagues. So in terms of data, I think, majority of the data that would be collected with regards to vaccines would be done by the ministries of health. And it's quite abundantly evident that the quality and the quantity of data for vaccine implementation and monitoring varies considerably depending on the capacity of the national public health system in the country. So from that perspective, the main limitations that I foresee is that the quality of data could be, poor in terms of accuracy and completeness. Similarly, we'll have gaps in data in terms of indicators and geographical coverage, and limitations in terms of standardization in what and how the MOH is collecting data. And then, of course, there are quite a number of other challenges, including, the public availability of data, and particularly data that's related to adverse events, and how we are going to have this kind of harmonized approach towards getting this data, because the context that we work in is quite diverse. And on behalf of IMC, I can say that all 30 countries that we work in, they are different in their own respect, and the type of population that we serve out to. So in that regard, there are quite a number of limitations. But then the other limitation that Rahul and Michael and Leela talked about earlier is the one that relates to hesitancy. So with vaccine hesitancy, this is going to be extremely challenging. I mean, we have seen in some countries that the private sector is now importing vaccines into the country, and thus the richer segment of the society is still able to access some of those vaccines. But then, if there is no sort of a harmonized and an evidence-based approach towards addressing this hesitancy across the countries that we work in, I think there will be sort of the relatively socioeconomic disadvantaged class would suffer a lot more because of it. So there are a number of challenges we foresee, but I'll stop here with the time limitations, and I'll pass it over to some of my other colleagues who are on the panel.
That's great. That very helpful perspective there. Emmy, FCDO is looking across the world really at all of the things that organizations are struggling with. What's your view on this landscape of the high level landscape of obstacles and opportunities?
Thank you, and great to be here today. It's afternoon here in Nairobi. I am a Science Tech Innovation Advisor. I'm based in Nairobi. I work with FCDO, as has been stated, specifically with the East Africa Research Innovation Hub, one of within Africa, one of 3 hubs, but we also have hubs in MENA and in Southeast Asia. I know some of the colleagues from the other hubs are on the call, so I'd also welcome their input at any opportunity. I think for me, the speakers and the presentations have covered quite a bit. I think what I would add, and I think it's like a double-edged sword, or a couple of things. So one is the issue around access. And I think it's just because of the multi-sectoral or multi-dimensional characteristic of data. So especially with a pandemic or in an emergency situation where you have, of course, the main ministry, as most of us would see it, with the Ministry of Health, but then there comes issues around food security and gender and women, as has been pointed out. So I think there's that issue around accessing data from other government departments or ministries. And then comes the issue around trust and being able to access that data and trusting the other departments or agencies' data. And again, coming to that, there's various actors that come in. There are the companies that are providing solutions, the private sector, their own data. Just so many layers of access there that I think is both a challenge but also an opportunity. And I guess for me, there are more questions than I can offer answers. What role do the NSOs play, and what does that mean in terms of strengthening some of those institutions? I think the other challenge, but also an opportunity, I think if we take advantage of the pandemic, is the issue of the lack of regulations and standards, and about data sharing, because I think there's that. We've seen what that has done with advancing the development of the vaccine, how the data was shared and taking advantage of digital infrastructure, and just, how everything is connected. And I think that is also something that can be a potential opportunity, but has been a challenge. Thank you.
Yeah, that's a terrific point to end on as well. I think that despite all the acknowledged challenges in getting data, sharing data, and all of that, you rightly point out that the fact that we even have these vaccines is the result of an unprecedented effort to share data across a variety of disciplines in order to get here. Surely we can do something similar with regard to the distribution of these vaccines in a way that gets them to people and gets them in their hands. So I think that's that the opportunity in sharing is great and greater, hopefully, than the risk of doing so. That's very helpful. Siobhan, you also have a bit of a portfolio view on this. It'd be good to hear your perspective as well.
Hi, I'm Siobhan Green, and I am the Digital and Data Governance Transformation Portfolio Lead at IMC Worldwide, co-lead of the Data Challenge for COVID Action. Been working in the space of ICTs and data really since they started. My master's dissertation was on the Internet in Africa, written in 1997. And yes, there was internet in Africa in 1997. So I have this very long-term view as well as immediate. And I would say that one of the things we found is that there has been a tremendous growth in just the capacity within LMICs. I know Africa particularly well, but there's also been a tremendous growth in investments and in demand. And so one of the challenges we find with COVID is the same challenge we find across the entire data landscape. Lots of investments that are not necessarily coordinated, siloing, data laws that might be lagging behind the technology. A lot of investment from donors and from other funders may not necessarily be fully integrated into governance structures by governments. And the result of this is this siloing, is the lack sometimes of interoperability standards, both of what does the data say and do? Can you connect the systems together? But also, do you have the permission to do so? A recent piece of work we did with UNAIDS looking at how to work with Africa CDC on building a dashboard, one of the biggest challenges they had about different countries sharing data was some of the political concerns around how this data was going to be potentially misused for political purposes. We also see these issues when dealing with confidentiality and the need for trust within communities, because oftentimes this data can be used for, say, law enforcement or other types of political gains. And again, highly marginalized populations are even more sensitive to some of these conspiracy theories, and in some cases, legitimate concerns about usage. So just to say that, you know, from the problems we see with data and COVID are unfortunately, and also fortunately, not unique to COVID. What this does mean is that if we focus on building these governance systems, making sure the legal protections and also civil society advocacy for appropriate responsible use of data is in place and supported, as well as really breaking through some of these silos and helping think more of a portfolio perspective. Again, it's that rising tide that lift all boats. As long as we make sure that what we're doing is not solely for COVID and really can build overall the immunization particularly, but broader health system data infrastructure.
Yeah, that's great, Siobhan. Thank you. And I myself remember being in Africa in the 90s and being excited by the truly exciting growth culture, growth mindset around the internet that every time you'd meet people, it was just this incredible energy and excitement around what the continent was going to do. So it was really wonderful to see it at that stage and wonderful to see it today. That's really great. And I want to now turn to Ravi, who at WHO and COVAX, of course, has got a view into the work that's being done on the vaccine supply side of things, and also in this COVAX level coordination down to the ministry level. Give us your thoughts on this bigger landscape that we're seeing.
Thank you, Lance. This is Ravi Shankar here from WHO headquarters here in Geneva. And I support the GIS Center here. We recently established a GIS Center, and this is one of our first portfolio work to support the immunization team on the COVAX vaccination rollout. So the way we look at from our angle is first to let the countries know that, hey, there are so many technical partners there. In the COVAX GIS working group, we are around 40 plus partners who are willing to do support to the countries. So the first thing is we are making this available to the ministries and the WHO and UNICEF country office, telling them there is support there and there are donors there who can help you on this. That's the first thing we are doing. Next is also to understand what is the need in the country actually? Everybody wants to support the country. We actually wanted to know what are the asks from the country in terms of geospatial area. Do they want to have a spatial population? Do they want to have a detailed DEM model there? Do they want to have the mapping of health facilities? So we're trying to have a understanding on what is the needs of the country. Then we're also doing a needs assessment or a benchmarking from the technical partners, because there are so many partners out there. We are sort of benchmarking everybody on what is their offering. So we are taking this to the countries and tell them, these people are willing to help you and this is your need. Who do you want to choose and how do you want to work? So that coordination work jointly with UNICEF and other donors like Gavi, Global Fund, BMGF and World Bank. This is the whole work which we are trying to get it out there. Thank you.
That's great. That's really helpful. I think, you know, having that view from sort of inside the COVAX and WHO control room, as it were, I think is really quite helpful. There are a lot of folks on this call who are probably in those discussions with you, but there are also probably a lot of organizations that need to do that level of coordinating. And I think that perspective really adds a lot. So really, thank you, Ravi Shankar. And now I want to also in that same sort of control room group of organizations, UNICEF, which is very active in close collaboration with WHO and COVAC. And we have Rocco to talk a little bit about some of the work that you're doing in that space as well. So Rocco, thank you for joining last minute addition to the panel. We appreciate your coming on here. Thank you.
Thank you, Lance, and thank you for the opportunity to be on the panel. And since I'm coming last of the panelists, I'm probably going to echo a little bit some of what was said before. I'm a geographic information system specialist at UNICEF Health Section in New York, and I am co-leading the COVAX GIS working group together in collaboration with WHO. I think many of the things, many of the barriers and main kind of obstacles have been mentioned, and I should say coming from a geospatial background, I think the wealth of data that have been produced by organizations like Surga and Frame is really essential and booming. I think when we look at the limitation on use at the country level, based on UNICEF experience, we really need to look at bridging the gaps in between availability of very high resolution information and how this can be used at the local level, and how these kind of very advanced products can be linked to specific service delivery mechanisms, for example, through microplanning and through the linkage of this geospatial information to information on communities and health facilities that is really the nuts and bolts on the vaccination service deliveries. For example, when we get very complex spatial information, how does that then relate to the information on the for the specific communities that community health workers will need to be supplied to in order to be able to make decisions. Looking broader than the geospatial side of things, I should say that some of the challenges that UNICEF is really trying to grapple with in terms of deployment of digital solutions is the fact that the urgency is potentially creating the rushed adoption of very ad hoc digital solutions that could lead into, and Shioban had already kind of touched on this, that could lead to further the fragmentation of digital health architecture in countries and end up somehow working against our long-term objectives to ensure that data and processes, digital data and processes are integrated across the MOH. But I think something great that is coming out of this situation is that both internally and externally, within these big organizations, the urgency has created a push for improving collaboration and interaction in between teams. And some of the examples as the the COVID action, as well as the GS working group, are probably and hopefully here to stay, and will create processes and resources that will be very helpful down the road. Over.
That's really great, Rocco. That's helpful. And I think that point that you made about sometimes innovation can uplift, but innovation can also fragment. If we've got too many people doing too many things on too many fronts in too many different ways, sometimes those things don't reconcile. They don't always come together into a cohesive whole. And I think that's really certainly something that we at NetHope keep top of mind, and that I think we all should as well, as we think about how we get the vaccines out quickly and efficiently to as many people as possible. So that's really great. There's a theme that's come up in a couple of times in the conversation, and we didn't really talk about this in our speaker prep yesterday, but I'm wondering if the panelists have a perspective on this, and that's if we think about this gathering here being focused on data integrity, gathering of data, weighing of data, mapping of data, all those things to help us get the vaccine to people. There's another kind of information that's circulating out there about vaccines, information, misinformation in various places in the world, and that's a problem we have seen in a variety of countries. And certainly the amount of that that's there or that must be countered or corrected in some way is a barrier in and of itself. And I'm wondering if folks on the panel see that as something that is that something that we're going to need to deal with in some significant way in order to get vaccines into the arms of people who need it, or is this not so much of a problem, or it's only a market by market problem? And Siobhan, I see you nodding there. I'd love to hear your thoughts on that if you have it.
Well, I want to point out something that Carmen actually said in the chat, which is that a sizable percentage, Gallup survey found 55% of Pakistanis do not believe in the virus, and only 4% of those who want a vaccine will accept one that's Western made. Here in the United States, we unfortunately have a terrible history of medical harms done to the African American communities and testing, which has led to very understandable distrust of the medical community. And then on top of that, you have the politicization of vaccines by various, and this is, I think, true across the world. So I do think it's a major problem. Really what it comes down to is trust. Who do we trust with information? Where do they get that information from us? And we have to think a little bit also when we do share very publicly information about individuals, there's going to be backlash potentially to that. And people, one of the things we find, and I do a lot of work actually with HIV as well as other marginalized communities like gender-based violence, people will use what we call privacy behaviors to protect their privacy. For example, they will give false names, they will give false birth dates and other identifying information. They will travel to a place where they know that they will be more anonymous. They will use proxies. And if they don't feel like they can really trust the healthcare providers, they will just not accept services. So, and we can't be seeing this necessarily as a bad action by these individuals, but rather it's a reflection of whether we've actually been able to build that trust with them. So vaccines are just are exactly the kind of intervention that we really need to be thinking about trust. And I know WHO, for example, has done a tremendous amount on the infodemic. So I'd love to hear more from Rocco and others around what they've done to address this.
Yeah, and no, that's great. And Ravi Shankar, I know you were also looked like you were about to jump in on something.
Yeah, I did not directly was involved in this, but I could share what was happening in WHO. The right word is infodemics. I did not know that word exists till COVID. Always we are talking about epi-intelligence. That is what was much talked about during the various crises. Now it's actually about infodemics. The first infodemic session which WHO conducted had like 15,000 people attended it. There was a webinar on that. And also, this is the best time during my period in WHO where I saw that there's so much public-private partnership. Facebook, Google, so many people came in and helped us with fake news, to identifying some of the fake news from our communication team, and then they were blacklisting and identifying the fake news and having more alerts on that. I think there's a lot of more help needed on that area. I see that that's a new area which is coming up with the social media and other things. If more community participation and more research and more NGOs work on that, I think that will be very helpful to counter the fake news and miscommunication out there. Thank you. Maybe Rocco wants to add more to that.
Rocco, please.
I'm not that necessarily directly involved in infodemic work, but I can definitely attest that there's been a strong uptake across UNICEF or across countries of digital content for frontline health workers and e-learning kind of tools that at the beginning of the pandemic we started very quickly to consolidate and to provide, for example, tools like Health Buddy or messaging content that can really it's kind of a low-hanging fruit in terms of technological investments, but can really reach the core of the problem, the community health workers, and support better training and learning and on some of these issues around hesitancy and demand. Over.
Yeah, that's terrific. Javed, are you? Is this a factor in the field work that that you're all doing there? Is this something that you're seeing and grappling with when you do direct delivery?
Oh yes, this is one of the biggest fear that we have. So once the vaccine becomes abundantly available in the countries that we work in, those are mainly low-income countries, I think one of the biggest factor that's going to be decisive in tackling this pandemic is going to be the acceptance from the population. And we have witnessed it across all the countries that we are working in, albeit at varying levels. Even when we started supporting the Ministry of Health in Jordan for rollout of the vaccine, we noticed that the vaccine refusal rate was extremely high. And that was also in population who had previous comorbidities, who were at high risk, who were considered to be, in the first stage of this vaccine rollout. And we saw that across the region. In Lebanon, we had similar concerns. We supported the Ministry of Health, did a vaccine hesitancy survey, and the results really, warranted that fear. And then, currently we are working in Pakistan to see what are those social and behavioral determinants of refusal, so that we can come up with, we share those findings with the stakeholders involved, and we come up with contextualized plan to address that. We also have similar projects in West Africa. Now, currently, we are rolling out a program in DRC with similar intent. But the theme across all these countries is the same. We have not seen refusal to a therapeutic or vaccine at this scale ever before in our 35 years of work. So this is incredible. It's huge. That term infodemic, certainly, when we were battling with COVID 1 year ago, it really truly reflects what we were witnessing. But now with COVID vaccine, it's at another level, and it's really proving to be challenging.
Yeah, I know that's very helpful. I mean, certainly we at NetHope know that, even though the term infodemic may be new, this is not a new phenomenon. We certainly faced this in the work that we did on Ebola a few years ago. And I think we're seeing a repeat of that phenomenon here, but it's just at a much greater scale because of the penetration of social media and all of the, frankly, insidious strategies for spoofing and repeating misinformation that now are in play. I want to turn the topic, because we only have about 5 more minutes here, but just one last point on this. I would like to point out that Rakesh Barana, one of our colleagues from Salesforce, has pointed out that that they have put together a list of thought leaders and experts in cognitive security working on this space. Those of you NetHope members may remember that Salesforce was our first featured speaker in this COVID equity vaccine series, and they are, of course, a global technology partner for COVAX directly. So would direct you to them to take a look at some additional resources there that may be helpful as you grapple with this problem. But in the last 5 minutes and before we turn to Q&A, I want to take it back to some of the systemic level concerns, I think. You know, we've got a bit of this ecosystem here. We've got governments wrestling with policy and sovereignty questions. We've got this idea we're trying to rapidly put infrastructure in place, and maybe we're dealing with legacy infrastructure from previous crises, and yet we want to do some work that hopefully has some utility going forward for the next crisis. You know, I think I'd like to turn to Emmy to give us a little perspective. As you sort of look out to where we might be in a year's time, if we have successfully deployed technology and data solutions, you know, to some of these challenges, you know, what might we what might we be leaving behind? What might we be leaving in place so that we can successfully deal with some of these issues? Not when the exact thing happens again, but when something similar happens again, right? Because we know that this is probably not the last global health crisis we're going to face. So do you have thoughts on that from the FCDO or the Africa Bureau's perspective?
Yeah, thanks for that. I'll try to answer a question with regards to, you know, probably if we're to look back in a couple of years when maybe this pandemic is over and we've sort of built some resilience or some systems to enable us to tackle another pandemic, because we're told this will not be the last pandemic. And also, you know, what we really hope actually that we will have built into health systems and data systems. I'm hoping that we will have done a lot of or contributed to a lot of sort of the plumbing that's you know, needed for efficient, you know, use of data, and that means you know, one, the ethics, the governance side, the regulation side, so that you know, there's that possibility to really leverage on data while ensuring that we're protecting people's data and their rights around that. The other thing I think that also speaks to some of our role as FCDO and the Research Innovation Hub where I sit is just the support that I hope we will be able to lean on and we will have built into our research and development systems. Because I think there's potential to provide that longer term impact, to enable us to continually innovate, anticipating new pandemics or, you know, variants, etc. And I think, you know, if we look at the current effort by the Africa CDC and the AU to manufacture vaccines or to, you know, build a capacity within African countries to you know, to contribute to that 99%, or rather to eliminate that 99% and increase the 1%. Local production, you know, a big chunk of that is just around, you know, building our R&D and enabling that tech transfer. So I'm hoping that we'll have, you know, worked around some of the issues that, you know, will enable that. I'm also hoping that the work that COVID Action is doing and everybody here around data, you know, will contribute to building the health system, in our health systems. You know, so looking at the broader health system and the supporting mechanisms around that, so that it's not just we're not just looking at, you know, we're not perpetuating the fragmentation that we're talking about, or the siloed nature that we're talking about, but we are really like, you know, enhancing the whole system. Yeah, I think I'll stop there.
Yeah, that's a really terrific point. I think keeping that idea of, you know, we should all be looking to robust health systems that support a broad population of people as much as we can be, and hopefully having our individual solutions as we're able to craft them and put them together to be, you know, pointing in that direction eventually. So that I think that's a very important point. Before we turn to Q&A, other final thoughts or comments here from anyone else on the panel about the kind of the system level landscape? Where do we go from here? Where is this taking us?
I just wanted to add a real comment. One of the challenges we have looking at it at a system level is that oftentimes the responses really do have to be unique to the country. And, you know, we know that prioritization, we know that equity is important, but what that looks like in each country is going to be different. Also, the political landscape is going to be different. We know that siloing is very common, but exactly who owns what is going to be different. So that's a real challenge. We can't have a one-size-fits-all global response, but we can have some global guidelines about what we've learned that generally works, and then make sure that we're really working at a country level and even sometimes at a subnational level to make sure that the solutions are responsive to the specific needs. And just as Emmy said, the goal is to build the health systems so that they can be resilient and sustainable, so that this gets integrated in and not necessarily created off to one side.
That's terrific. So I think we're now going to open up the questions. Oh, I'm sorry, Rocco, did you have a?
Yeah, I just wanted to quickly chip in also. It's an aspect that I think it's important at the global level. One of the things we'll hopefully inherit from this is a improvement or a more efficient coordination of funding channels and mechanisms for digital innovations. This was clearly has been kind of a bit of a bottleneck in terms of the global funders understanding how to better channel through development groups and so that technical partners can kind of access the end and be linked to countries through the proper mechanisms is something that will hopefully have been in a better place the next time we face a global situation like this. Over.
Terrific. Let's open it up to questions. We've got a lot of good questions. I think Kelly and Diana have been collecting some. What's popped in early here that we can get back to?
Great.
Yes.
So there's an interesting thread happening in the conversation with Stacey from Sabin and Ben McCormick and Michael Bailey, which is about black box technologies being used here. You can't see what's happening under the hood, and then kind of juxtaposed with data standards and all that kind of stuff. And I think that'll be a great question for the panel to try and wrestle with, that the need to have real business reasons, real algorithm reasons that happen, but also the need to share data and get stuff out here. So let's start with that one. Let's try Ben. Maybe you can start. Maybe you can give more detail on that. I see you've come off mute.
Hello. So I guess what we were discussing was the way in which I suppose there are several issues with hard-coded black box analyses. Firstly, that are they black box and you don't know what they're doing under the hood, and therefore how do countries feel ownership of that analytical method and the results and have confidence in it? The second is about, I suppose, it being hard-coded. So for example, with the frame, Carmen described the way in which it was built on the WHO framework. So then how responsive would it be to adaptation for local needs? Alongside that is the sense in which if people are, so there's a lot of data collection and a lot of focus on high resolution data. Are they the right data to answer the needs of a given country? So if a given country has a different sense of what their priorities would be, or how their priorities are shaped, or has adapted the WHO roadmap, how responsive could these tools be? And are you then bound by the data that you've paid to have collected or collated? Or is it possible to adapt to have different data sources? I think that touches on this issue of sustainability. Sorry, that was the end of my rant.
Diana, I just might add that I think this is an issue that in the work that we've done for a long time, it comes up so regularly. And I just think that it really is at the heart of how to think about data-driven solutions and in a sort of universal agreement that they are important and they're really critical to improving and optimizing outcomes. We know that in the context of COVID, we know it in in the context of so many other health issues. Yet at the same time, it is so important, and this gets back to Siobhan's comment about how there is no one size fits all solution, and ensuring that the users of these data have that confidence and a clear understanding of how it's been generated and how it's being used is just so critical to ensure sort of the political viability of those outcomes, and also sort of the public confidence in that decision-making process.
It's one of those multiple trust indicators, right? Which was also
exactly.
another thread that was happening on here. And I believe, Rakesh, you had started some of the conversation about trust and that kind of stuff as well.
Exactly.
Yeah, I think that from a trust standpoint, this is Rakesh from Salesforce, by the way. From a trust standpoint, we are operating this global response in a fundamental crisis of trust backdrop, right? That's the underlying subtext to everything that we're doing in almost every community on the planet right now. And so I think that's one thing that we have to absolutely grapple with, and how to do this in the most trustworthy, transparent way possible. And then I think the corollary to that is really around sustainability. And I just wanted to just highlight that, based on the work that we did with NetHope and others, even back in during the Ebola crisis, and even going back to H1N1 back in 2009, usually at time of crisis, there's a lot of attention, there's a lot of resources. And then once the crisis passes, there isn't, a lot of times the capacities are not sustained for the next one. And so like what we saw this time is that a lot of the stuff and a lot of the collaborations that we saw during the Ebola crisis basically atrophied for lack of interest, I think, in the intervening years. And so now we're back at, we had to go back to square one in many cases. And so I just wanted to put it to all of our speakers to just opine maybe on how do we create a sustainable capacity coming out of this that advances our interest, not just in day-to-day health, but even in preparation for the next one. And the assumption is there will always be a next one.
Great question, Rakesh. Panelists, thoughts about this, getting past this boom and bust problem of having lots of resources flow to an acute problem and then flow out again once at least the momentary crisis seems to have passed?
I think there's a lot of lessons that we can pull on for that. I mean, first of all, obviously Ebola is a great example of what, in many cases, what to do and what not to do. But also I would say that some of the funding priorities we see right now in global health, for example, how much money goes into HIV versus other types of health areas. I mean, you have a lot of situations, for example, in Africa where only HIV patients are the ones who have an electronic medical record. But if you're not HIV positive or not at risk of HIV, then you don't get included into digitized medical records. And that's entirely down to how the funding is allocated. So I think it comes down to, oftentimes, going back to Emmy's point about working with governments and making sure that donor priorities are not over, we understand that donors obviously have priorities and they have their obligations back to their home governments and so forth. But understanding that if we do want to have something that is sustainable long-term, it can't have this siloed health sector by health sector type of approach. Even, for example, with public health issues like gender-based violence, I did an assessment recently in Malawi where, depending on where the funding was coming from, even though there was an attempt at collaboration, there were just very different systems. And there wasn't any kind of coordination or planning around it. And again, from a patient-centered healthcare perspective, if the person dies of COVID or dies of HIV or dies of, in childbirth, they're still dead, right? We still have an obligation to help them. And the data shouldn't care about what the disease is. And I think if we can bring these lessons in as we're applying to COVID, I think that will do a lot to help build that sustainability and resilience.
Maybe Lance, if I can chip in a bit of a response to Ben's McCormick point about some of the the high resolution advanced spatial products as black boxes, and the use of that information. A good example of that is also, for example, high resolution population estimates and the political friction against the use of that acceptance of that kind of information. And I think some of the good and I think promising approach we have seen is the transfer of the capacity to at local level through research institutes or universities. And I'm thinking here, for example, about the Bill and Melinda Gates Grade 3 approach of building the capacity in the National Statistical Institutes for running the models and then leveraging this institute's linkage with the Ministry of Health and voice with the Ministry of Health to improve, reduce that friction in between what we call now operational population data set versus official population data sets. And also UNICEF has had some relative success in, for example, in the use of exposure, vulnerability for geospatial data, such that of frame, that are sometimes very complex indices by linking with local institutes like Emory Research Trust in Kenya that have an existing relationship with the ministry. So I think I see that as a promising model for resolving some of these issues. Over.
Yeah, I think that we've got civil society, public health, and data and technology on this call, but government is kind of the hinge between all of those things. And I think as we move to the last couple of minutes on the panel, I think Kelly's got a question that will deal with that, and then we'll move into closing remarks. Kelly, did you?
Yeah. I just had, and I mean, I think we've touched on it a little bit, but I noticed someone in the chat was saying how it's really important to obviously build on existing relationships and strengthen capacity. And I feel like I heard something similar from Ravi and Rocco about wanting to understand the data needs from the governments before we just go in and, build or offer tools. But I guess I'm just wondering from the panelists if there's any kind of ideas, and maybe especially from Emmy, just kind of how we can better assist LMIC governments, knowing that they are so stretched and have all these multiple priorities, and how can we actually, make their lives a little bit easier in resolving and working towards distributing vaccines and prioritization and all of that.
Well, yeah, I think a couple of points have probably answered the question indirectly, but maybe what I could add, and I think this is the approach that the COVID action team is taking, and I think I would laud that. In addition to, of course, deepening the relationships or leveraging the relationships that are already there. Is just when we deploy these tools or technologies, I think new tools are great, and I think when there's an emergency, you'll try to scamper around and try to find something that could help you in that moment. But I think what happens then is that we tend to forget the systems that are already there, and we tend to recreate new stuff, and then once the pandemic is over, whenever it'll be over, we up and leave, and I think that's a challenge. For instance, currently, what systems have been used to deploy, routine immunizations, and to what extent is the current deployment of COVID vaccines using that? I don't think that's happening, at least in the context that I am aware of in a couple of countries. There's that issue of, there's that issue of, new systems, new whatever's just being set up to do this. Yet there are already systems that exist. There are people who are, they have the knowledge, they have the capacity to sort of deliver that. And then I think, and I could give an example of community health workers, and I haven't had a lot about community health workers, but I could be wrong. Leveraging their network to do some of this work. And I think for us as probably funders, there's a lot of work around how we fund, I think, and our funding models. And that has already been touched on by, one of the speakers. And just always considering the concept of sustainability and, pushing our partner countries to invest more in research and development, I think, just because if you look at the BioNTech example, I think it's taken a long time. The mRNA technology I read today, it was 40 years old before it was first, used in the US. So I think there's just that need to constantly think of sustainability when we engage with partner countries.
Emmy, thank you for that. And I think we're up on time and we'll have to leave it there. Thank you, panelists. Really engaging conversation, putting not only a range of technology ideas and solutions on the table, but a number of contextual variables that are going to be required for that technology to succeed. And I think we need to keep our eye on both those things. So that's really wonderful. I'd just like to say in closing that, the NetHope member community and our extended network of friends and collaborators, which includes all of you, are about impact and action, and all of us together are a platform for unique collaboration and scale to tackle this crisis. And if we're successful, we may also be able to leave infrastructure, standards, and frameworks and relationships of trust in place that will help us with the next global health crisis. I'd just like to mention to members as well that we on staff and members of the Board Development Committee will be reaching out to you shortly to discuss the fund. So please watch your feeds in the member portal and the email for outreach. But in the meanwhile, we really want to thank our panelists and our friends and collaborators at FCDO, IMC, COVID Action, and all of the very important organizations and work represented on the stage today. We'll have to leave it there for now, but expect to be connecting with you and working with you soon. From NetHope, many thanks, and I'm now going to turn it over to Mike for a few final thoughts, details on the fund, and to close us out. So Mike.
Great. Thanks so much, Lance. And a thank you as well to the fantastic panelists we had and the participation, generally speaking, because CDO colleagues, WHO, UNICEF colleagues, International Medical Corps colleagues, IMC colleagues, we had UK AIDS speakers, Frame, Surga, GPSTD, Sabin Vaccine Institute, Priorityvax. It's just been a really great session. I think we've covered a lot. So a big thank you for everyone for taking the time, a couple hour slot out of your Thursday to talk about data needs and data gaps and the tools that are addressing them. In terms of the fund, and I would be remiss if I did not have a colleague drop in a call to action, specifically here in the chat that you can go to and look at the open fund. And it was really heartening to hear over the course of this session how well I think the approach to funding innovation tracks with what we've set up here, which is to say an open call that looks to government needs in terms of data gaps first, as well as ongoing and existing programming in this space and relationships with tech providers, as well as NGOs and others that can raise their hand and say, I think we can broaden and or deepen our existing work together to deliver impact to close some of these data gaps. And just simply, that's what this open call is about. It's a two-stage process. The first stage is telling us about what this particular solution is and how it can begin to close data gaps in coordination with government. And then the second is we'll be taking these applications as they roll in to FCDO, as well as to a whole host of other donor actors that we have on the call here as well, our friends at the GIS working, that COVAX GIS working group sponsored by UNICEF and WHO. And the idea is that we'll be going through this two-phase process to look at the applications that are coming through and then funding these concepts to bring these solutions online in a sustainable way. So again, thank you, Lance. Thank you to NetHope for allowing us to kind of take over one of these call sessions. It's been really wonderful to work in coordination with you and your team. And thank you for everyone joining today. We had great participation, awesome dialogue as well with all of the questions. And a big thank you again to everyone for joining.
Thank you so much.